This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Hemorrhage. Want to know why cocaine is used in the operating room? What toxin has been used in bombs, impregnated into clothing, and sprayed on salad bars? What rat poison is treated with vitamins? Today's episode starts in the emergency department with your resident presenting the case of a 22-year-old man with epistaxis, i.e. a nosebleed. His nose has been oozing for several hours and the bleeding just won't stop. The resident examined him without finding an area amenable to cauterization, and she says it's oozing from both nostrils. She told the patient to hold pressure, then tried oxymetazoline, brand name Afrin in the U.S., a nasal spray causing vasoconstriction. Neither of those interventions worked, so she wants to try tranexaminic acid, a blood clotting medicine. And she also wants to send labs, including coagulation markers. You agree with the TXA, but the lab work seems unnecessary in this otherwise healthy patient without any past medical history who's not taking any medicines. Question number 1. Other measures that might help include A. Cocaine, B. Turmeric, C. Hot packs. The answer is A. Cocaine is actually great for nosebleeds. Turmeric has some anticoagulant properties, meaning it theoretically could increase the bleeding. And hot packs cause vasodilatation, also potentially increasing bleeding. Conversely, ice packs aren't proven to help, but they may be helpful. It's less and less commonly used these days, but liquid cocaine is used by head and neck surgeons during surgery because it's a great vasoconstrictor and it's a topical anesthetic. I've used it a few times myself on their advice for refractory epistaxis. You soak a cotton pledget in the liquid. It's usually a 4% cocaine hydrochloride solution, and you put it inside the nose. I've also taken care of post-op patients with symptoms of cocaine toxicity like a racing heart rate and high blood pressure after it was used during surgery in the operating room. Wait a minute, did I hear you say, doesn't cocaine cause nose bleeding? Yes, that's also true, but the difference is chronic versus acute use. Chronic vasoconstriction leads to loss of the blood supply in the nose, resulting in dryness and ultimately tissue deterioration, particularly in the septum, leading to septal perforations and nosebleeds. Epistaxis is an extremely common complaint in the ED. Question number 2. Nosebleeds are commonly caused by A. Nose picking, B. High blood pressure, C. Dry air. Well, if you answered this question at all, you got it right, because the answer is A, B, and C. Most cases of nosebleeds are very low acuity, and they're caused by nose picking, dry air, or high blood pressure. Very rarely, it's possible for epistaxis to be life-threatening. We divide the blood vessels in the nose into 2 sections, anterior and posterior. The vast majority of bleeds are anterior. Posterior nosebleeds are a true emergency, and patients can actually bleed to death. I've only really seen one serious posterior bleed in my entire career, and I am not exaggerating when I say the entire room, including the walls, were covered with blood. The resident insists that she wants to send the labs. Why? I mean, this is clearly not a life-threatening case. But she reviewed his chart, noting that he was just in the ER 2 days ago for hematuria, i.e. blood in the urine. So the case is getting a little bit more interesting now. The urinalysis showed blood, but not infection. He was treated with antibiotics anyway as a precaution. He doesn't have abdominal pain, suggesting a kidney stone or some other pathology. The patient is still having blood in his urine, and he's told the resident it's gotten worse, though it's still painless hematuria. So she convinced you about the labs and sends off a blood count and coags, also known as a PTINR and a PTT. You go in the room to examine the patient. He's pinching his nose. Nevertheless, blood is still oozing from both nostrils. His vital signs are as follows: temperature 98.6 Fahrenheit or 36.9 Celsius, heart rate 90 beats per minute, blood pressure 120/80, respiratory rate 18, and oxygen saturation 100% on room air. He gives you the same history he told the resident, so you move on to the physical exam. His affect seems withdrawn, meaning he's not showing a lot of emotion and isn't making good eye contact, but to be fair, he's trying to talk to you while pinching his nose. Looking inside the nose, you agree there's no focal bleeding, just general oozing. His heart and lung exam are normal, as is his abdominal exam. You do notice a lot of bruising on his skin. He shrugs, saying he's not sure how he got all that, but maybe he bumped into things he wasn't aware of. This seems like a simple case, but now we've discovered some red flags. He's got 3 signs of bleeding: nose, urine, and skin. And none of these problems are particularly concerning on their own, but taken together, they are concerning for coagulopathy, the medical term for blood clotting disorders. We don't want to send him home to return with something that is life-threatening, like an intracranial hemorrhage or a GI bleed. You ask if he's had nosebleeds, easy bruising, or any other bleeding before in the past. He says no. All right, so what could this be? Of course, you know about hereditary diseases like hemophilia. There are acquired problems, including the use of anticoagulant medicines, all of which cause bleeding as a side effect. Warfarin, dabigatran, and rivaroxaban are examples. Multisystem organ failure can lead to DIC or disseminated intravascular clotting, for example, in patients with severe sepsis. If this were hereditary, he'd most likely have had prior episodes of bleeding. And he's obviously not in multisystem organ failure while sitting comfortably there on the stretcher. He says he's not taking any medicine. An hour later, the resident gives you an update telling you the tranexaminic acid worked and the nosebleed stopped. His labs are back. His hemoglobin, i.e. his blood count, is normal, so are his platelets. Important for blood clotting, as I'm sure you know. Surprisingly, his coags are elevated, both his PT-INR and his PTT. These tests reflect the function of different parts of the coagulation cascade. And the tests are not just mildly abnormal, but extremely elevated, and so high the lab doesn't report an actual number, but says the INR is greater than 10 seconds and the PTT is greater than 140 seconds. In fact, we're lucky he's only having some bruising, a nosebleed, and some bloody urine. He's at serious risk for having an intracranial hemorrhage or other emergency with these numbers. You and the resident try to figure out what this means. The nurse interrupts to tell you the patient is vomiting up blood. Neither of you is alarmed. Patients with nosebleeds also swallow blood, and blood is very caustic to the stomach, causing a lot of nausea and vomiting. So this kind of thing happens a lot. The resident checks on him, saying the blood is red rather than darker like old blood, but his vital signs are fine. She sits back down to discuss what these coags indicate. Before you get anywhere, the nurse insists you come into the room. The patient is now vomiting up copious amounts of red blood, making it difficult to believe that this is just a residual effect from the now resolved nosebleed. His heart rate starts to go up, suggesting a potentially significant amount of bleeding. You tell the nurse to start a second IV, start some IV fluids, and add on liver function tests. In addition, you ask her to repeat the hemoglobin in 4 hours to see if there's any change. You tell the resident to call GI and hematology, and you ask the patient some more questions. He denies alcohol. He certainly doesn't have any stigmata of cirrhosis or liver disease on exam, and not surprisingly, his LFTs come back normal. The patient's mother is now at the bedside. She says he's been depressed and she's worried he, quote, took something, quote. She doesn't know what. The patient continues to deny everything, but she did notice his flat affect on exam, i.e. his lack of reactions, which is a sign of depression. The patient is not participating in this discussion, so you ask her what medicines are in the house. She says her metoprolol, her warfarin, as well as aspirin and acetaminophen or Tylenol. This isn't a metoprolol overdose. That's a blood pressure medicine and it causes slow heart rate and low blood pressure. This isn't Tylenol because that generally doesn't cause bleeding and his liver function tests are normal. Could it be aspirin or a warfarin overdose? You ask her how much warfarin was at home in the bottle. She doesn't know and doesn't know when it was prescribed, so it could be any amount. You go to tell the resident, who in the meantime has spoken to hematology. They said coagulopathy with elevated PT and INR but normal platelets could be caused by a vitamin K deficiency, clotting factor deficiencies like factor 5 or factor 10 deficiency. They recommended more tests, including levels of some of the clotting factors, which the resident orders. They also recommended a medicine to stop the bleeding. That's question number 3. What medicine might help with this patient's bleeding? A, vitamin A, B, vitamin B12, C, vitamin C, or D, vitamin K? The answer is D, vitamin K. Let's talk briefly about how your blood clots then come back to why vitamin K helps. Blood clots form via a multitude of steps. First, the platelets form an unstable plug. Our patient isn't having a problem here, but with the second part, the clotting cascade. This is an amazing but complicated sequence of events activated by bleeding. Clotting factors catalyze a sequence of reactions to form a stable plug, i.e. a blood clot. We could spend an entire episode discussing it, though I'd probably die of boredom, so let me sum it up as succinctly as possible. Clotting factors are named with Roman numerals from 2 through 12. Hemophilia, for example, is a factor 8 deficiency. The basic tests we use to evaluate this process are the coags I mentioned earlier, the PT-INR, and the PT. Now, medicines can disrupt the clotting process, as I'm sure you're aware. Aspirin is an antiplatelet agent causing platelet dysfunction. So this patient hasn't had an aspirin overdose because in acute overdoses, it causes acidosis, rapid breathing, and an altered mental status. Bleeding from aspirin occurs really only with chronic or subacute exposure. And even if that were the case, it does not affect the PTINR because, as I said, it works on platelets, not the clotting factors. True anticoagulants do work on the clotting cascade, and warfarin, brand named Coumadin, thins the blood by inhibiting vitamin K. How does that work? Well, factors 2, 7, 9, and 10 require vitamin K for activation. So if you don't have vitamin K because you either never ate any or you're taking warfarin, which is inhibiting it, then your clotting factors can't work, so your blood becomes thin. Now, warfarin requires frequent PTINR checks to ensure the blood is thin enough to prevent blood clots, but not so much so that the bleeding risk outweighs the anticoagulation benefit. We do have newer anticoagulants called DOACs. These work on other parts of the clotting pathway. The benefit to them is you don't have to check the patient's labs. So could the patient have taken his mother's warfarin? Yes, and I'd be very suspicious that that was the case. But other bleeding disorders still need to be investigated by the inpatient team. As I said, our patient's coags are extremely high to the point where his blood might not clot at all. If we give him vitamin K, the inactivated clotting factors will start working, hopefully, and we can administer vitamin K either orally or intravenously. Oral vitamin K is very safe, but it takes a while to work, like 12 to 24 hours. IV vitamin K works much faster. You can see effects as early as 2 to 4 hours, but it's actually riskier to give it IV. Why? Because IV vitamin K causes severe anaphylactoid reactions, probably due to the diluent it's dissolved in. Remember, anaphylactoid reactions are drug-induced histamine release, causing a reaction like anaphylaxis. This is an uncommon but very serious side effect with IV vitamin K, and a small number of patients have actually died from this. So you have to weigh the risks and the benefits of oral versus IV. In this case, the analysis favors IV since he is really at risk for life-threatening bleeding. Your resident gives him a dose in the ED and admits him to the inpatient team. They'll monitor his coags and titrate the dose accordingly. 5 days later, your resident follows up on the case and tells you the patient's PTINR is still abnormal despite massive doses of vitamin K. Every time the team tries to lower the dose, his INR goes right back up. All of his clotting factor levels were normal, as was the workup for other rare diseases per the hematology evaluation. Now we have a case of an otherwise healthy man with a prolonged clotting problem in whom the rest of the workup is negative. If this were a warfarin overdose, the patient's PTINR really should be improving by now. Your phone rings. Heme wants a tox consult. So you re-interview the patient without learning any new information, but something is definitely missing from this story. One of the difficult parts of medicine is determining when to believe the patient and when to suspect that they're lying. So it's on us as toxicologists to figure this out. As I said earlier, there are a number of toxins causing bleeding, and anticoagulants are really at the top of the list, particularly warfarin because it did cause the pattern he has on the coags. But it should have been better by now. So it's a little bit confusing. Warfarin is actually a really interesting drug, and that's question number 4. What plant is warfarin derived from? A. St. John's wort, B. clover, C. foxglove, D. mandrake. The answer is B. clover. In the 1920s in Wisconsin, it was noted that cows were dying of a hemorrhagic disease after eating spoiled sweet clover. Coumarin, a fairly benign compound in the clover, is actually converted by penicillium mold into dicumarol, which is deadly in large amounts. So warfarin, named after the Wisconsin Alumni Research Foundation, was marketed as both a rat poison and a medicine. Warfarin is both an extremely useful and an extremely dangerous drug. It's been called one of the most dangerous drugs. It's been responsible for thousands of hospitalizations. In 2007 to 2009, it was responsible for 33,000 hospitalizations in the U.S., according to the New England Journal. Warfarin's potency is affected by diet, like eating foods high in vitamin K, and it has a lot of drug interactions, including some as benign as just taking antibiotics. So if frequent lab testing isn't done for dose adjustments, patients can easily develop clots and/or bleeding. So in our case, this looks a lot like warfarin toxicity, but as I said, warfarin really shouldn't last this long, and his INR should at least be improving at this point. So what could cause this prolonged anticoagulation? That's question number 5, and it's time to pick your poison. A. Scorpion envenomation, B. Pesticides, C. Rat poison, or D. Methamphetamine. The answer is C. Rat poison. On this podcast, we've discussed tons of toxins used as rodenticide, including arsenic, strychnine, and carbamates like aldecarb. Check out episodes Murder in Medicine, Three Little Steps, and The Culinary Catastrophe for more. Our patient is poisoned by a super warfarin found in modern rat poison preparations. Shortly after the invention of warfarin, rats developed resistance, leading to further research and the development of super warfarins. There are a bunch of different ones, but common names include bromadiolone and brudificum. What's the difference between warfarin and super warfarins? The only thing is the duration of effect. Both work exactly the same by inhibiting vitamin K. Warfarin lasts for days, but the effects of super warfarins last for weeks or even months. So back to our patient, I'd be very, very suspicious this is a super warfarin exposure. How did he get exposed? Probably ingestion. These types of exposures are more common than you might think. Kids eat the pellets or bite the blocks fairly frequently. There's good data showing the kids will be fine. The vast majority don't even develop minor bleeding. This is because a bite or a pellet is a low dose. A small child, say 20 pounds or 10 kilos, would have to eat 8 pellets to get sick, and this just isn't likely in an exploratory ingestion. If you do have a kid who gets exposed to rat poison, the Poison Center typically recommends a PTINR in 48 hours because both warfarin and super warfarins take at least 2 days, more like 3 to work, and they advise strict precautions to avoid head injuries, though, as I said, typically nothing happens, not even a bump in the INR. On the other hand, though, intentional exposures, like with a suicidal person who eats rat poison, is much more serious. Suicidal patients often eat boxes of rat poison. It reminds me of a case and the precautions you have to take. In the U.S., most suicidal patients in the emergency department have to wear a gown or paper scrubs, ensuring nothing is concealed on their person. We even empty out the hospital rooms to prevent injury, including getting rid of the monitors, as patients have tried to strangle themselves with the wires. That said, I once consulted on a patient with a super warfarin rodenticide ingestion. Asking for specifics about the type and the amount that he had taken, the person gestured to a bag sitting on the floor in their room which had another 10 boxes of rat poison sitting in it. Fortunately, I got the bag out of the room before it was too late and they ate more. Anyway, back to our patient. After a discussion with hematology, everybody is convinced this must be a super warfarin. Heme recommends sending brudificum and bromadiolone blood levels, which will take a week or so to come back. Eventually, after several days, with the help of psychiatry, the patient finally reports ingestion of rodenticide due to suicidal thoughts. He says he ingested 10 boxes of rat poison he found in the back of his garage. Quick aside, in the U.S., the Environmental Protection Agency increased the regulation of super warfarins to protect wildlife, and so many rat poison manufacturers changed the ingredients to other types of poison. Does this mean our patient couldn't have taken a super warfarin? No, for a bunch of reasons. First, people keep things in their garages for years. See cases of people poisoned with coyote poisons like compound 1080 long after it was banned. Second, you can get almost anything on the internet. And third, commercial use of super warfarins by pest control is still allowed in the U.S. So a call to the patient's family confirms that they do have brudificum, a long-acting super warfarin rodenticide, in the garage. Brudificum is 100 times more potent than warfarin, and as I said earlier, it has a long half-life in humans, with estimates ranging from 16 to 36 days. That's more than a month. Hematology recommends ongoing massive doses of oral vitamin K with INR checks every few days. Typical doses of vitamin K are like 5 to 10 milligrams, but for super warfarin ingestions, doses as high as 400 milligrams per day have been reported. Fortunately, the patient never develops life-threatening bleeding. If he did, other treatment options include a fresh frozen plasma transfusion or something called PCC, prothrombin complex concentrate. That's a tongue twister. And both of those contain clotting factors. What's actually the most difficult about cases like this is not the treatment, but figuring out the best disposition. So disposition means whether the patient stays in the hospital, goes home, or goes somewhere else like a psychiatric facility. Why is it difficult? Because the patient might be anticoagulated for weeks or even months. And staying in the hospital for that long not only costs a fortune, but is associated with risks including infectious diseases like COVID, antibiotic-resistant infections, and medication safety errors. If this was a patient who, for some reason, was accidentally exposed to a super warfarin, you could titrate the dose of vitamin K to a stable INR, then discharge them for serial lab tests to taper it down as an outpatient. However, you can't assume a patient with suicidal ideation will take an antidote, much less follow up for blood tests. In one case of super warfarin ingestion, the patient's INR was abnormal for 7.5 months. So each of these cases, in my experience, raises specific issues and are managed on a case-to-case basis with input from hematology, toxicology, and psychiatry. Most cases of exposure to superwarfarins are due to ingestion. However, inhalational exposure is possible. There was an outbreak of bleeding after patients who smoked K2, the synthetic cannabis derivatives, across the U.S. because the K2 was contaminated with superwarfarins. Several patients actually died from intracranial hemorrhages after this, and it was never discovered if the contamination was intentional or unintentional. But this outbreak raised another issue, the cost of vitamin K in the U.S. These patients were regular non-suicidal patients, so they were titrated to a vitamin K dose, then discharged, as I said, to follow up as an outpatient. Many of the patients returned to the hospital with serious bleeding. Why? Vitamin K costs as much as $65,000 per month. Yes, I was shocked to read this for a vitamin. So after hearing all this, you probably won't be surprised to know that superwarfarins have been used in both murder and terrorism. A 70-year-old man was poisoned by his wife, upset that he had had a baby with his girlfriend. He required vitamin K for 5 months. A mentally ill person in Michigan sprayed a Whole Foods grocery store with brodifacoum, believing people were poisoning him. I don't believe anyone became seriously ill after that. Meatloaf inside a Rikers Island jail in New York City tested positive for brodifacoum. Nobody knows if it was a contaminant or revenge of the prison guards after the attempted sexual assault of a female guard. Pipe bomb in Washington state in 2011, fortunately unexploded, was found to contain brodifacoum, and it's reportedly also been used by Palestinian suicide bombers. I have to say, though, that doesn't make a ton of sense from a toxicology standpoint because the bleeding risk wouldn't start until a few days after the injury, at which point the victims would be either dead or alive. And as I mentioned earlier, small exposures are very low risk. There are allegations that the Rhodesian military poisoned insurgents in the 1970s in Africa with clothes impregnated with warfarins. Back to our patient. Attempts to find a psychiatric facility willing to accept a stable patient requiring ongoing medical management fail. He stays in the hospital for 5 weeks until his INR normalizes. This is a fictional case, as are all our cases, to protect the innocent. However, it is based on real poisonings. The last question in today's podcast. Blood-thinning drugs have been derived from all of the following except A. Sweet clover, B. leeches, C. pigs, D. mussels. Follow the Twitter and Instagram feeds, both at PickPoison1 for the answer. Remember, never try anything on this podcast at home or anywhere else. Thanks for listening. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Until next time, take care and stay safe.